incision for the work is going to be straight dorsal on the joint. You'd think with a medial plate you would want it more medial. However, the most important part is, as you'll see, is getting the osteotomies done from dorsal to plantar. And to make sure that you can reach the lateral aspect of the medial cuneiform and the first metatarsal base, you really need to go dorsal. And you're able to easily get the soft tissues retracted and get the plate medial, as we'll see. Back. Just leave them out for a second. This will free up the sesamoid apparatus and remove any plantar adhesions. Kind of focusing laterally. Okay, there you go, Random. So now we've got it fully mobilized. You can see the difference. Now it's totally mobile. You can just push with your finger and the distal first metatarsal head will almost come back where you want it. So our work here is done. Now we'll go up to the proximal incision. And just make a plane. Make a little pocket for retraction on the tendon. You can get that retracted out of the way along with the vein. And then you've got a nice tissue plane down to the joint. Most of these you have a lot of hypermobility and you can just dorsiflex, plantar flex, and that helps you locate the joint. I can feel it right in here. So there's the joint. And I'm just going to make a linear capsulotomy here. Again, kind of dorsal medial. And you can start sharply reflecting initially. So we're just going to try to expose that first tarsometatarsal joint. And you want to, it's very important to visualize all the way laterally so you can see, so you can make a full correction. One of the errors you can make is only addressing to about 3/4 of the first metatarsal and not getting all of it. Well, this will block your reduction because you're not removing all of the lateral bone. So just take some extra time. Make sure you have all of the medial cuneiform exposed, all of the dorsal first metatarsal head exposed. So I'll kind of begin it sharply, and then we'll get that middle woody. Sections that this joint is about 3 centimeters tall, so and the plantar ligaments are extremely strong. It'll make your life easier removing the bone wedges here momentarily if you do a little extra work getting all the plantar ligaments freed up. Also, we're making sure we have plenty of room for our plate. So we'll grab with a small plate just for sizing purposes. Well, but the joint line is the laser line here. And so to save you the trouble of having to go back a second time, I'll hold it up and you can kind of size up where it's going to be and know that you have to have this much retracted and dissected free. So I'm going to need a little more distally to make our lives easier. Got a 15 blade. Aspect of the medial cuneiform, and that's kind of what causes the deformity. And making the correction, you can see that's where the correction is made. We'll be simply removing the cartilage off the base of the first, and to make that correction, if we reduce the deformity, techniques for fusing this joint. Some people just want to reduce it, and that can be done as well. I prefer to do the 3-plane correction to show me where it needs to go, and then make the matching cuts. And so to correct in the frontal plane, so we'll just run that K-wire in. And now if we can get the C-arm draped, I'll show you the difference that it makes doing only the frontal plane adjustment. So we'll be working on doing the frontal plane correction, transverse plane correction, and then the sagittal plane. And the combination of those three will get it where we want it to be. Place there, directly under. So before, sesamoids are more lateral, and then just rotating that K-wire upwards and providing a little squeeze, and you get the sesamoids directly under the metatarsal head. There's several steps here. So what we want to do is we want to rotate in the frontal plane. Transverse plane, we're going to squeeze in on the transverse plane. And then to set the sagittal plane, if you dorsiflex the hallux, that'll pretty much get you in the ideal position. You can always check that by feeling the lesser metatarsal heads where it is. So you can kind of see the frontal plane variation. What a big difference this makes. So you need to do both that and transverse and then sagittal. Before we do the osteotomies, you can see the angle now and how that changes during the correction. That's where it needs to be. Without any bone cuts, this is where it's going to be, bunion deformity. So we're going to make the osteotomies match the corrected guideline. The only other variable is because there's some fiddle factor. And so I like to put the saw blade in so you can identify the correct plane. Errors that can be made are, you have the angle off and you'll take too much bone on the first metatarsal base or not enough, too much dorsal, and you end up dorsiflexing the metatarsal. So to avoid that, you put your blade in the joint, you know that this plane is correct. We also know that there's a little curve to the first metatarsal base. So to avoid just getting the dorsal and plantar aspect only, just come a millimeter or two proximal, and then you get the whole cartilage plate. Skinny Homan. Meters of bone from the lateral aspect of the cuneiform. But the important thing is keeping the correct plane. So you want to again run the saw down the base and then make that match. Get that all back. There we go. Okay, so just double check that you're in the right spot. Here's the plane. Okay, now we'll get our rongeur, our osteotome. Let's get a lamina spreader. Fragments out. If I come out with this one, and then let's get an osteotome. You can use a combination of curettes, osteotome, and rongeur to breed the remaining surfaces, making sure everything's nice and smooth. Rongeur, please. Okay. With good bone-to-bone approximation here. So this is really the key component of successful outcome is good joint prep for your reduction. Go ahead and see a curette as well, just so I can show that. I'll do both sides, and we'll flip the lamina spreader. You have it on the lateral side while you drill central and medial, and then we'll flip it and retract the medial side and drill lateral. Keep keep it. And before we start doing fixation, we're going to reduce everything, get it held, and hold a temporary guide wire just so we don't lose everything that we've tried to gain here. And then once that's all set, we can proceed to fixation. We need this to get up there. Devices, so I'm going to try to get a stable lateral position, which will be out of the way, and still do the same. But that was just a convenient spot for me to place that. And I'm going to go back and try to come a little more lateral on the first metatarsal base and get a good strong hold out of the way. Okay, so we should be held with that. You can feel it's in a good position. You've got a little limitation of dorsiflexion there, but not bad. We can still get it dorsiflexed. Okay. So any problem? So we're going to line up the joint line to the fusion site. Make sure our plate is nice and medial. Soft tissue is reflected. We've got our joint line on the fusion site, and we're going to pin it distally first. And then we're going to use the dynamic slot to get our compression on the plate side. I don't think we need that pulled back. I just think we need this pulled over here. Good. Okay. So you have freer in place. You have your laser line on the joint line. And we're going to place this this pin at the proximal aspect of the dynamic hole. So then we apply our clamp device. We'll get a few millimeters of compression there. It is possible to slant it and slide it in. See the guide remover. Easy, and replace them later. Portion, you have your clamp in place. I like to make sure this doesn't move the fusion site, so I'll continue to hold it where I want it while I do a squeeze, so we don't have any change in your reduction. It only needs a couple of clicks to make a lot of impact. You see joint fluid coming out of the joint. So now you have a solid squeeze there. With your compression placed here, we're now going to get our compression through the screw. So this one's going to be in the way. I think we've got it held solidly with this one, first one. Plus we also have the added fixation here, so it's not needed as much anymore. Here a little bit. Okay, so the guide, it has a slotted entrance, but with the compression device in place, this will slide over and push it all the way down. Now you have this slot of variability where you can centralize your K-wire and place your guide wire for your compression screw. Right there. So the only thing that can really mess you up is if this isn't held in place. So starting point. We have a cannulated guide, or a cannulated depth gauge. This is the X-ray. About our length. Let's get a 34. Did the screw do the work? So again, holding your deformity so you don't have any movement, holding the correction of your deformity, and you can have a countersink just to avoid any stress risers here. Have a cannulated end on it just to get a preparation for the screw. And then if you like, you can place your wire back in for your screw placement. So you get your proper screw size. Sample of the screw, you've got partially threaded 4/0 size. But having the guide just makes your life easy to not have to taking place. And now with this compressed here, our compression device immediately, we're going to lock everything into place. So if we can get the guide back, the little guides back, if we can retract here, we have our compression. Now we just need to lock in. We're in before you drill, especially on the locking screws. You'll want to remove them before you measure. Just get the screwdriver. Get a 16 regular. Pardon, cortical. Yeah, cortical. Being a non-locking screw, when you get the, you can see it, compress the plate down to the bone there. Now on your second screw back here, we can lock that one in place. So if we can retract and get the other nubbin on there. Any nubbin. Get it. Let's get a 14 locking screw for here. Once we're held, we have to hold what you have.
14 locker.
We can remove this pin, which was in our dynamic slot. These are threaded, so you have to reverse. And then one at a time, we can remove one, because you still don't have anything locked vertical. Get one to suck the plate down and one to lock it. That one's locked. And the cannulated screwdriver. We'll look at our x-ray. That. But you can see the IM angle is back to 0, so any remaining bump is prominent eminence, and that's what we'll go back and shave off. So you've got the deformity corrected, your IM is back to 0, sesamoids are positioned underneath the metatarsal head, and so that's where you want to be. Any remaining bump we'll clean up for aesthetics and for avoid any potential shoe gear irritation. Thus far, we haven't had any complaints of plate irritation. If you run your hand down the side, it sits nicely along the medial column. There's nothing to palpate there. The dorsal screw, if you use the countersink, is nice and subset. I can't feel the dorsal prominence. And you have your result. The rest is closure and routine layers. Again, post-operatively, 4 to 6 weeks non-weight bearing on healthier patients. I'll check an x-ray at 4 weeks. Someone you're a little more concerned about, will wait a full 6 weeks, check x-ray and get them progressive walking. So really, if you try to stress this construct, you're not opening it up. So if you have non-compliance or an issue such as that, and a patient wanted to walk on it, I wouldn't be terribly concerned. However, with the non-union rate that we discussed before being 10%, it doesn't hurt to be extra cautious and go ahead and protect your patient a good 4 weeks with a boot and crutches and then progress after that.